Hi, everybody. Dr. Horn with Infectious Disease. So today we're going to go over, it was the top 10. It's become the top 17 things your infectious disease physician wishes you knew. So you're getting more than you bargained for. You're getting uh, your money's worth because you're getting some extra things thrown in there. Now, some of these things are um, like a fact here and there, I guess, but some of them, most of them, could be talks all by themselves. They could be multiple talks. So this is going to be something a little bit different because it's going to be instead of just one topic in depth, it's going to be, something, a lot of things that you might see day to day or come up very frequently, or questions I get all the time from not just from one place, but from all over. So that's why it's included here, is that there are things that might make things a little bit easier, or just a fact here and there that can be helpful. Um, So if you have any questions, feel free to type in any questions in the chat. And most of these things, I think these kind of talks where we just hit the highlights and just like the high yield things, I think some people really like them because, it's just kind of fast and you hit the highlights and if there's more things in depth, you can go over it, or if there are any of these you want me to expand into another talk, I'd be happy to do so. And then I think some people might feel like it doesn't go as in depth as you want it to go, but that's not really what it's meant to do. This is kind of a different style where we're hitting th- common occurrences, often things that come up very frequently that you know, good things to know and things that um, the most high yield things I can think of. So starting with number 17, the goal of antimicrobial stewardship is to get patients on the right antimicrobials. So that's something we want everyone to know because sometimes people think of antimicrobial stewardship as people that call and stop things, right? And people that call and don't want you to give things. But it's not about money. It's not about approving things. And we don't just call and say, stop carbapenem, stop daptomycin. It's about getting people on the right drug. And this other point here, time to effective coverage is the most important factor for a good outcome. I was thinking about making that one on its own because the most uh, important thing when it comes to treating infections is getting someone on the right antibiotic um, as soon as possible. So usually when people fail, it's drug choice and not drug duration. So it's time to effective therapy. So antimicrobial stewardship, the goal is to get people on the right antibiotics. So, having a daily review, looking through and seeing if patients are on the right drug for the right bug, for the correct amount of time is important. So, if you get a call, it's not always stopping an antibiotic, but it might be adding an antifungal, adding an antiviral like acyclovir. So, antimicrobial stewardship, is more than just stopping stuff, although that's a big part of it. I think we stop, uh, well, it feels like, and I know some people, some antimicrobial stewardship pharmacists and some ID physicians will say they stop more antibiotics than they start, which is probably the case. But it's not always about stopping, and sometimes people will say that they just think we're going to stop stuff all the time. So number 16, blood cultures are discussed in sets. So when I hear someone say 4 out of 4 blood cultures are positive, they often mean 2 out of 2. They often mean 2 blood culture sets were positive. So each set is going to be one aerobic and one anaerobic bottle. So all 4 blood cultures grew the organism. So I encourage people to think of this in sets. So what that means is that When a person gets blood cultures, they'll get one set from one arm, so aerobic, anaerobic from one arm, aerobic and anaerobic from another arm, and then so that's two sets. So one set from one arm, one set from the other arm. So really we think of in sets. So if one aerobic bottle goes positive from one set, so if you do aerobic and anaerobic from one arm, that's one set. And if one of those bottles goes positive, that's a positive set. So if the anaerobic also goes positive in that arm, I'm not very interested. Okay. So it's just that went positive. And then if the other arm, the other set goes positive, that'd be two out of two sets. So if someone says, so yeah, so I would say two out of two sets are positive for MSSA. But if someone calls and says four out of four positive without telling me the number of sets, it's incomplete information. So I don't know if they mean two out of two uh, sets went positive, and then the repeats were also positive. So if an infectious disease doctor says four out of four went positive, they mean that two out of two, and then the repeats went positive. But sometimes people will call and say four out of four went positive, and they mean bottles. And so um, that's just two sets going positive. Um, so I just wanted to mention that because this is something that I hear all the time. And then whenever I hear four out of four went positive, I have to ask, for more information and what exactly that means and everything. So number 15, don't use clindamycin alone for an animal bite. So this is important. So clindamycin has poor activity against gram negatives, poor activity against Pasteurella, which is most common, which is one of the most important pathogens in cat and dog bites. So clindamycin monotherapy leaves a significant gap in coverage. So clindamycin covers gram positives really well. So it can cover strep and it can cover staph. It doesn't cover MRSA very well, so I wouldn't use clindamycin to cover MRSA. That could be probably a separate one. But clindamycin, gram positives, so it covers strep well and some anaerobic coverage. But when you're talking about a bite, which some of the most important things are gram negatives, like Pasteurella, like Eikenella, Capnocytophaga, so these things are all gram negatives. And if you look at, and this is something that happens all the time. So people think, oh, it's an animal bite. They have an allergy to penicillin. I'll give clindamycin. And they'll give clindamycin, and the patient may get better if they had a strep infection, but oftentimes they'll get worse. And they'll continue to get worse. Um, and then they'll come in and we'll want to add coverage for gram negatives. So if you look in, is it Sanford Guide at what antibiotics to give for an animal bite, it will have, the drug of choice for patients that are outpatient is going to be Augmentin. And then Sanford Guide would say clindamycin, no, 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 no. So it would be okay to give clindamycin if you add something that covers gram negatives as well. So if you give clindamycin plus levofloxacin, that would be okay because the levofloxacin would be covering the gram negatives. So if they have an antibiotic allergy, like a penicillin allergy, then you can come up with a regimen, but even a later generation cephalosporin plus clindamycin or a later generation cephalosporin plus metronidazole would probably be even better. So patients that get clindamycin and continue to get worse, oftentimes their hand was bitten by a cat or a dog. They continue to get worse, and then they'll come in with worsening hand infection that can be really devastating. And every so years, there's an article in the newspaper of someone that was bitten by a cat or a dog on the hand. They continue to get worse, and then they need some fingers taken off, and they were a piano player or something or a guitar player. So that's not great. And it's this happens pretty frequently that we see this. Number 14, uncomplicated UTI treatment for 3 days in men and women. So this is a new change, and that's why I included it, is that it was perhaps, I think, a year ago or so, where they changed the classifications. Uncomplicated UTI, infection confined to the bladder in afebrile men or women. So both men and women are able to have an uncomplicated urinary tract infection, and you can treat for 3 days. So this is a change, but this is important because it changes therapy. And, it makes sense to me. It's always kind of made sense to me. I never really understood why, you know, I understand it's more difficult for a man to get a urinary tract infection, but once they have a urinary tract infection, 3 days should be good. So complicated UTI is now defined as pyelo. So it's anything outside the bladder. Pyelo, if they have a fever or if they're bacteremic, so that's outside the bladder, fever, bacteremic. Catheter associated is complicated, or prostatitis, which is not covered here. But if it's a urinary tract infection, if it's uh, confined to the bladder, then 3 days is enough antibiotics. Okay, number 13, beta-lactam, beta-lactamase inhibitor combinations already provide excellent anaerobic coverage. So if someone is on beta-lactam, beta-lactamase inhibitor combination, so if they're on piperacillin tazobactam, ampicillin, sulbactam, then that has anaerobic coverage and you don't need to add metronidazole. So this is something we see um, every so often, is that someone's on like a Zosyn or a Unison, and then they're also on metronidazole. So it's not needed. That has good anaerobic coverage. Carbapenems also have good anaerobic coverage, so you don't need to give, say, meropenem plus metronidazole or ertapenem plus metronidazole. The carbapenem already has good anaerobic coverage. Okay, so number 12, elevate the leg if the erythema resolves, then it's probably not cellulitis. So this is another one that if we're seeing a patient for a possible cellulitis, when we see the patient, it's sometimes hard to differentiate cellulitis from other things like edema. If someone's leg uh, swells up really quickly, it can be erythematous, so it can be red, it can be warm, it can be painful. It's hard to know if it's cellulitis sometimes. So what I'll do is if the patient's able to lie down, they can lie down. I'll raise the leg up if they're able to do that. And while I talk to them, while I get the history, I have the leg high up in the air if possible. And sometimes, right when you lift the leg, all the erythema just resolves and it goes away. And if that happens, then I sign off. I say, this is not cellulitis. Thank you for this interesting consult. And no antibiotics are needed. So oftentimes when I do that, the resident or fellow or med student, whoever's with me, will be really shocked. And then afterwards they'll say, I didn't think that was going to work at all. And I'm usually like, what? Like, I thought we were a team here. I thought we were on the same page. Um, they'll be really surprised it worked. And sometimes when we tell the team that it's not cellulitis, by the time the team gets back to the room and they'll look at the patient, they'll look and they'll say, oh, the foot is red again. And they'll get worried. So oftentimes, if we raise it up, we'll try to take a picture of it and put it in the chart and show that all the erythema resolved when the leg is raised above the heart, higher than the level of the heart. So we'll either get a picture of it or we'll ask the resident to come and look at it with us and we'll show them. And you can evaluate for new onset heart failure or something, try to get the edema off. But no further antibiotics are needed, and that's a good plan because antibiotics not only will they not help, but they can cause harm, as we'll talk about later, and they can cause diarrhea, and they'll cause extra fluids, extra salt on the patient if you have something. Uh, Sometimes several antibiotics going pretty regularly. So um, if we're worried that they have cellulitis there and an infection, I try to change to pills if possible while the team is trying to get all the fluids off and give Lasix and things. Number 11, ampicillin is the best antibiotic for enterococcus. So this is something that's good to know. I think it's important because just last week I talked to a hospitalist about treating a patient with enterococcus and what drug to give. And in order of preference, IV ampicillin is generally considered the drug of choice. So IV ampicillin, amoxicillin is going to be the oral equivalent. So you can give PO often, if they have a urinary tract infection with enterococcus, you can give PO amoxicillin, it'll get into the urine well. Penicillin G is another option, although penicillin G not as good as ampicillin. Now, if you can't give ampicillin or amoxicillin due to a penicillin allergy, then what would be the next best drug? So usually the next drug is going to be vancomycin. And if you can't give vancomycin, then linezolid or daptomycin, but not a cephalosporin because enterococcus is intrinsically resistant to cephalosporins. So the key here is don't give a cephalosporin for enterococcus. Sometimes the patient has been getting cephalosporin for a few days when we see them, and since it doesn't have any activity, if the patient has no urinary symptoms when we see them, and they've been giving something that has no activity, they probably have asymptomatic bacteriuria if we're treating enterococcus in the urine. But if it's in the blood, especially you want to be giving ampicillin. And that's also why, in the susceptibility result in the testing, that's why they don't include any cephalosporins and they wouldn't test it. If they don't believe something's going to work or it's intrinsically resistant, they wouldn't test it, and that's why it's not there. So ampicillin is the drug of choice for enterococcus. I could also add here, if someone has VRE, if someone has vancomycin-resistant enterococcus, then vancomycin would be resistant, but you can't assume that ampicillin is also resistant. So when someone calls and they say patient has VRE, what should I give? Then my next question is it susceptible to ampicillin? Because sometimes it will be susceptible to ampicillin but resistant to vancomycin. So it would need to check the susceptibility report and make sure that ampicillin wouldn't be an option either, because just because it's vancomycin resistant doesn't mean it's automatically ampicillin resistant. So next, number 10, a single dose of tobramycin or gentamicin is enough for an uncomplicated UTI. So here I'm including susceptibility report for Klebsiella. This is going to be an ESBL organism. So ESBL producing isolate. So you can see it's resistant to ampicillin, the cephalosporins. Now, here, if it's susceptible to gentamicin or tobramycin, you can give a one-time dose and that will cover an uncomplicated UTI. So they can, if they're in the ER and they say, do we have to put it in a midline? Or if they see it in the hospital, they can give a one-time dose of an aminoglycoside and call it done. Okay? And that's good because the patient doesn't need a line. They don't need to be continued for several days. Like as we were saying before, 3 days for uncomplicated UTI. If they're in the ER, they can get a one-time dose and they're good. Okay. Now for ESBL, I guess the other thing that people would say is that you need a carbapenem, and that's not always the case. So it used to be that ESBL organisms, they'd say you always need to just ignore the antibiogram and ignore the susceptibility report and um, give a carbapenem, but that's not the case. So if you have this in the urine, if it's susceptible to levofloxacin and the patient can take levofloxacin, you can give that. If it's susceptible to Bactrim, you could give that. If it's susceptible to nitrofurantoin for a urinary tract infection, you can give that. So unless there's another contraindication, you could do that. Number 9, imaging is often unreliable to evaluate soft tissue abscesses. So this is another thing I wish people would know. And to go with your clinical suspicion, the reason is because it's not uncommon. So every so often, I'll see a patient and they'll have something on the skin and I will push it and I'll say, I think this needs an IND. And I'll come back the next day and the resident, uh, you know, I wouldn't be the one doing the IND. It's usually the surgical teams. And I'll come back the next day and the resident will say, oh, we did an ultrasound and it didn't show an abscess. And I will say, I can feel it, right? It's red. I can see it, I can touch it, looks to me like an abscess. I think they need an IND. And they'll say, well, the ultrasound didn't have anything. And I'll say, please do an IND. Come back the next day and they'll say, IND wasn't done. And they'll say, yeah, we did a CT scan. And I'll say, well, I can feel it, I can touch it. So the CT scan isn't great, right? So with just any kind of cellulitis, you're going to see some fluid, some edema there under the skin, and then in imaging. But whether or not there's an abscess there or not, I would leave that to clinical suspicion. So if you think the patient has an abscess, I would get an IND. And this isn't just hospital teams, this is also surgical teams. Um, there have been times in the past where, I say, there's an abscess there, I recommend IND. There are several times in the past that stand out where there was a surgery resident that said, we did a CT scan, so that proves it. And I said, I don't think it proves it. I can feel it. And I said, what time is your attending rounding? And then I rounded with them. That resident was not very happy. And the thing he said was, I said, if you could just, do a small cut, a small exploratory. And he said, oh no, if there were an abscess there, it would be a big procedure. Yes, but that would be a procedure that is needed, right? So the attending pushed on it, was also unsure. And he said it might help. And they did poke it and it went in 8 centimeters. It was in the thigh and it went in 8 centimeters. And the CT scan didn't see anything. So, and that to me is not unusual. So, if you have clinical suspicion for an abscess, it'd be a good idea to try and see if there can be just a limited, poke it, see if a bunch of pus pours out, and really that might be enough, right? It depends how extensive it is, but I always like it when it gets poked and you see if pus pours out because really that's what it needs. Source control is much more important in these cases than antibiotics. Um, so another part of this is that IV contrast is sometimes needed. So people will say, yes, we did a CT scan, but it wasn't with contrast. And oftentimes that won't see anything. We've had patients that abdominal CT without contrast, and then one was done with contrast and just saw abscesses everywhere, fluid everywhere. And then also for the head, sometimes I've talked to radiologists, and there was a radiologist that said, oh, we'd be able to tell, it wouldn't look normal. But it depends on the size of the abscess, it depends on the situation. And I've definitely had patients with brain abscesses that were not seen without contrast. So if you're going to do a study looking for an abscess, I do recommend IV contrast. Number 8, source control is often more important than antibiotics. So the best antibiotic cannot overcome inadequate source control. So abscesses need to be drained, infected devices need to be removed. Um, Gallbladder cholangitis needs to be drained, relieve obstructed urinary systems. Once the obstruction is relieved or the abscess is being drained, you have source control. And it depends on the situation. I know some ID doctors stop antibiotics once there's a drain in an abdominal abscess. Once the urinary system is relieved of an obstruction, that's probably all they need, although we would give antibiotics, but that's the most important thing. So sometimes, if there's a case that someone says, oh, they're too sick to have a procedure, give antibiotics. It's really, you want to kind of think of at what point would the surgery be done, right? There are some patients that keep coming back, keep coming back. I know I recently discussed a patient with a large staghorn calculus in their kidney and they had ESBL, and they kept coming back, I think 3 or 4 times. It was once the antibiotic was stopped, within a week or so, they would come back to the hospital in sepsis or septic shock. And the urologist said, oh, they're too sick to have, no, they said they're too malnourished to have surgery. Well, it's tough. It's a tough situation because with ESBL, they'll have need to be on IV antibiotics. So how long would you go with IV antibiotics? They can't really be on IV antibiotics for months and months while um, uh, because they're malnourished and it's really a tough situation. Cellulitis is likely from strep. So this is another important one that we see all the time. Oftentimes people say they have cellulitis, they must need MRSA coverage. And although Staph aureus is the organism most frequently isolated from needle aspirates or punch biopsy samples of cellulitis, cultures are negative more than 70% of such samples. So 70% of the time, it's negative. Strep pyogenes and other beta hemolytic strep cause the most cases. So cellulitis therapy should be directed primarily at beta hemolytic strep. Now, the caveat here, the thing to kind of think about is that when you have cellulitis, there's either pus or no pus. So here we're talking about no pus. So if there's no pus, then you can target strep pyogenes, group A strep. So beta hemolytic strep is the most common cause of cellulitis. Now, if there are abscesses, if there are pustules, then you can think of MRSA. Now, is this 100%? It's not 100%, but it's pretty good. If things are, if there's erythema, if there's a cellulitis, if it's spreading quickly with no pus, the most likely cause is strep. And so you can target strep. Now, MRSA is the most common cause of pus. So if there's an abscess with pus, then it's most likely MRSA. So that's the difference there. So you don't always have to cover MRSA if someone has just a straight cellulitis with no pus that's spreading quickly. Remove devices whenever possible. So does the Foley still need to be there? Does the PIC still need to be there? Does the central line need to be there? Can the port be removed? Oftentimes, we'll see a patient with a port and we'll say, do you need the port? And the standard answer is, uh, I think so. I'm not sure. It's like, so they'll say, with patients that have cancer, even if they were treated 10 years ago, they'll say, uh, they'll say, I think so, I'm not sure. Or if they were treated 3 years ago, they will say, I have another scan coming up at the 5 year mark. So oftentimes the ports are used for chemo, and then they're just left in. So if they don't need the port, it'd be a good idea to remove the port if possible. Otherwise, it's just left in and becomes infected. And when the patient says, I'm not sure, it's because well, they're usually not told anything about removing the port. So they're usually I'm not sure. And then also they'll say I have another scan coming up in a couple years. So ideally, removing those ports would be a good idea. Same with the Foley, same with the PIC. If they're not using it, it can be a problem, and it's not helping, it's just hurting. Number five, broad spectrum antibiotics are not stronger. Now, I don't usually think of antibiotics as big guns. I think of, although I understand the calling them a big gun, but it as shorthand. But broad spectrum antibiotics aren't stronger or necessarily better. So if someone's getting a carbapenem and a carbapenem isn't really indicated, like pre-surgery, if instead of cefazolin, some surgeons want to give a carbapenem because they feel like it'll reduce the likelihood of them getting an infection even more, and it will be better. It's not necessarily better. It's actually hurtful because it's giving them unnecessary coverage and um, you know, causing resistance, more likely for C. diff, more likely for having issues like diarrhea. So risk for adverse events increases by 5% for each additional day of antibiotic therapy. So I know some well surgical specialties, they feel more comfortable when the patient's on broad spectrum antibiotics. But that's not necessarily the case. It makes me more uncomfortable when they're on broad spectrum antibiotics and it isn't needed. There is a question in the chat. What about mesh in an infected surgical wound? So mesh in an infected surgical wound is an interesting topic. There are some types of mesh, like metal mesh that it's really important to remove. There are some types of mesh that don't get infected as much, and I'm told by some surgeons that there's some mesh that can clear, so that if you treat, you can actually resolve the infection. I think it depends on what the mesh is made out of and the situation. So that's a good question because I don't know that there's one specific answer for that encompasses all types of mesh. So it depends on the type of mesh, it depends on the situation. So broad spectrum antibiotics are not always better or stronger, so narrow when possible. Number four, respect Staph aureus. So don't ignore it, even if it's 1 out of 2. Staph aureus bacteremia generally requires at least 2 weeks of antibiotics. So sometimes people will say, oh, it's 1 out of 2, it's probably contaminant. It might be a contaminant, but I wouldn't ignore it. I wouldn't say it's a contaminant. There are some things that I would never call a contaminant because it can be really bad. So Staph aureus, Pseudomonas, um, any kind of fungus like Candida, 1 out of 2 blood culture is positive. Even if you think it's a contaminant, I would still treat. Staph aureus in urine should prompt a search for another source. So it's also every so often we'll get a consult for Staph aureus in urine and we'll look and the patient hasn't had blood cultures and they might have had a fever. They might have been feeling unwell for a while. We'll say that that was probably in the blood. And Staph aureus being in the blood and then coming out in the urine is much more common than Staph aureus starting as a UTI and then going to blood. So if there's Staph aureus in the urine, my first question is, could this have been bacteremia? The microlab might have additional information. So this is something also that I talk to people very frequently, and they'll say, I'll ask about an antibiotic. I'll say, is it susceptible to this or that? And they'll say, oh, it wasn't tested. Now, there's something called cascade reporting. And if a carbapenem susceptibility results are not reported for E. coli if the isolate is susceptible to ceftriaxone. So if there's an antibiotic that it's susceptible to, that would be more, first or second line, then they wouldn't repeat the later options like carbapenems. So if you don't want people using a carbapenem, you don't report it on the susceptibility report because it might be that the options to treat something like E. coli might be multiple times a day. It might be susceptible to unicin, and someone will look at the susceptibility report and say, "Oh, unicin, but that's several times a day. Let's give ertapenem because that's once a day." And that's really not what should be done. The ertapenem should be reserved for patients that don't have other options. So this is sometimes the case, if a patient has options when it comes to penicillin, or in this case with E. coli, if the patient has, if it's susceptible to ceftriaxone and carbapenem's not reported, but the patient has a ceftriaxone allergy. So ceftriaxone can't be given, and you might look at the susceptibility report and say, oh, there are no other options. I don't know what to give. But if you call the lab, they'll say, oh, uh, it was susceptible to ertapenem, but we suppressed it because it was susceptible to ceftriaxone. So calling the lab can sometimes be very helpful, and they might have more information that's not shown in the report or just more information in general. So this also is true of fluoroquinolones. There are some institutions that suppress fluoroquinolone results because they don't want people using fluoroquinolones because there might be better options. So in those cases, if you call, because the clinician that I talked to will say, oh, fluoroquinolones weren't tested, and it might have been tested, it just wasn't shown. Positive culture does not equal infection. So I think everyone was probably waiting for the asymptomatic bacteriuria to be to be in here somewhere, but this is encompasses asymptomatic bacteria, but a positive culture does not mean they have an infection. Oftentimes, if someone calls and they said, we cultured this and it's growing that, I'll say, why was the culture done? And it's because I want to know, was the patient having a fever? Were they having symptoms? Were they, do they have a high leukocytosis? What are the symptoms the patient's having? Because sometimes, things might grow on the skin, things might grow in wounds. And this is another thing with, doing a PCR of a wound, it's gonna identify something 100% of the time. Same thing with Foley catheters. If you do cultures of urine, the patient has a Foley, then it's going to grow something. And the question uh, becomes, do they have an infection or not? VRE and stool doesn't require treatment. This used to be a question we'd get all the time, where they'll say the patient has VRE and stool, what should we do? And the answer is do nothing. Heterococcus is common in urine, and just because it has some resistance doesn't mean it's causing a problem, right? And then number one is PO antibiotics can often be used instead of IV. And this is something that it's being a big push. So as durations of antibiotics are going down, and also um, the use of IV antibiotics is going down. In place, we're doing a lot of PO antibiotics because it gets in really well. We have antibiotics that are very bioavailable. They work very well. So there's nothing magical about giving IV antibiotics. As long as the antibiotic gets to the site, then you can use um, the PO antibiotic. So osteomyelitis. So it used to be dogma that osteomyelitis can only be treated with IV. So it's not true. Joint infections also don't need IV. Um, Endocarditis. Starting IV and then switching to PO. Bacteremias also, it depends on the bacteremia. It depends on the situation. But if you're using a PO antibiotic that gets in very well, then you you can do that instead of IV. Let's see. So I do have some common dogmas. I have some top ID dogmas that have been debunked. I see we don't have too much time, but I don't have too much here. These are some things that previous dogma, MSSA bacteremia, the traditional teaching was nafcillin or oxacillin are gold standard and better than cefazolin. Well, it turns out that cefazolin is just as good as nafcillin or oxacillin if it can be completed. And people are more likely to have problems with nafcillin or oxacillin than cefazolin. And if they have problems with nafcillin, oxacillin, like an allergy, then they change to vancomycin. And it's important to know that beta-lactams are superior to vancomycin. So I wouldn't give vancomycin for MSSA because the outcomes are worse than a beta-lactam. So because people can tolerate cefazolin better than nafcillin or oxacillin, cefazolin is the drug of choice. So I would give cefazolin for MSSA if possible. And here's another study. Previous dogma, metronidazole cannot be given with alcohol. So this was something that everyone knows about, and it turns out it's not true. The evidence for this was really not there. So metronidazole, there is no interaction with alcohol, and it's one of those things where, I had been an ID doctor for probably 8 years or so, and I had never seen metronidazole cause a disulfiram-like reaction. And, we treat a lot of people that drink a lot of alcohol, and I would have thought I would have seen it in 8 years, including all of my other training. So that was a dogma that was debunked. Also dogma, pancreatitis requires a carbapenem. So this is not true. So there are other antibiotics besides carbapenems that can penetrate into the pancreas well. This is still something I see every so often. People will be giving a carbapenem for someone with a pancreatitis because they were taught that only a carbapenem can get into the pancreas. Not true. So if you look here, adequate penetration, you have piperacillin, tazobactam, cefepime, metronidazole, carbapenems, fluoroquinolones. So you could be giving ceftriaxone, um, and that would be just fine. You can be giving lots of different things. You don't need a carbapenem. Another previous dogma, atelectasis causes a fever. We see people with atelectasis all the time. Atelectasis is normal. It doesn't cause a fever. So This is something I was told in med school, and I always wondered why that would be the case, and it turns out it's not the case. Previous dogma, osteomyelitis can't be treated with PO antibiotics. So this is also not true. I recommend looking up Brad Spellberg. He has a website and goes over a lot of these things. He has a lot of articles going over dogmas and debunking things, and I am a fan. So if you go to his website, you can look up shorterisbetter.com and Brad Spellberg, and you can see. But osteomyelitis doesn't need IV, and this is something that we run into frequently. And then perhaps we'll call the surgeon and they'll say, I've been treating osteomyelitis for 30 years. I know how to treat osteomyelitis. Well, things change after 30 years, right? So it's important to keep up with, pills are good options. And they actually did studies with pills versus IV for osteomyelitis, and the pills worked very well. And they said, well, that can't be. And they did another study, and then another study, and another study. And then they have a mountain of evidence and more evidence for pills than IV. But people sometimes get stuck in their ways. Previous dogma. Bactericidal antibiotics are always better than bacteriostatic. So this is also something that I learned in med school, that bactericidal antibiotics are better, and you can only use bactericidal in septic shock and things that are really important to treat. And that's not the case. So this has been shown not to be true. So it's important to pick an antibiotic that works for this specific case, but not rely on cidal or static. We had to memorize that for all the antibiotics, and it was not helpful. Previous dogma, all bacteremias need 14 days of IV therapy. So this is from Brad Spellberg's website, and it looks at short versus long courses of antibiotics. And the shorter, even for community-acquired pneumonia, they did ultra short courses of 3 days with people in the ICU, and they did fine. And shorter is better. It's not equal because the shorter duration of antibiotics, you're not getting all the problems with the antibiotics. So shorter is actually better, but the result here when it comes to the studies was equal. And then if you go to his website, below this, it has all the randomized controlled trials. So here are 14 randomized controlled trials showing that shorter is better for community-acquired pneumonia, and it kind of goes through. There are some exceptions like tuberculosis and some other things, but shorter is better in general. And this is the, I think, number one dogma. Antibiotic resistance occurs because the patient stopped their antibiotics early. So they used to say that if there's resistance, it's because the patient didn't complete their antibiotics. It's the patient's fault. They should have taken the whole course and they didn't. So it's their fault that we're getting resistance. And that's actually the opposite, right? So this was way wrong. It's actually the longer you give antibiotics, the more likely they are to develop resistance and the bigger problem it is. So they used to think that if you continued therapy beyond the resolution of symptoms, that it would decrease the likelihood of having a reoccurrence of that infection. And not only is that not true, but it's also causes resistance. So might be something that we've all heard. It's very likely that everybody has heard that you have to complete all of your antibiotics, or you're going to cause resistance, or you're going to cause problems. Okay, any questions about that? I see that we're at time. All right, if you would like me to expand any of these to a different webinar and talk about any of them specifically, or have any questions about any of these topics, please let me know. Otherwise, if you have any patients that have any issues, you can call us anytime and we'll try and help with whatever we can help with. Thank you, everybody. All right, have a good day.